addiction medicine, harm reduction, and changing your mind. My name is Brittany Page, and this is another special interview edition of The Page Perspective. Those are just some of the topics that we cover today with our very special guest, Dr. Melody Glenn, author of the new fantastic book, Mother of Methadone, A Doctor's Quest, A Forgotten History, and a Modern Day Crisis. In addition to being the author of this book, Dr. Glenn is the Associate Professor of Addiction and Emergency Medicine at the University of Arizona. She combines writing about her own life and journey into addiction medicine and advocacy for harm reduction with investigative reporting into the life of Dr. Marie Neiswander, who, together with her husband, Dr. Vincent Dole, researched and discovered how methadone could be life-saving and transformative in the treatment of opioid addiction. In a moment when there are so many serious issues competing for our attention, it is important to highlight addiction and the treatment of addiction, given the many millions of Americans across the nation who are struggling with substance use, but who also struggle to obtain treatment given the barriers that exist. Dr. Glenn offers a hopeful message in this book and in this interview. I am so grateful that she took the time to come here and educate us about the barriers to accessing what is gold standard treatment in the form of medications for opioid use disorder, stigma, the role of racism in creating our drug laws, the importance of harm reduction when it comes to treating addiction, the importance of access to things like Narcan or naloxone for overdose reversal, but how harm reduction can't stop there, and much, much more. Her book is out now, and you can find a link in the pinned comment to purchase. But for now, enjoy this conversation and let me know your thoughts in the comments. And now we're joined by Dr. Melody Glenn. Dr. Glenn, thank you so much for being here.
Thanks for having me.
I finished your book. I loved your book. It gave me a sense of hope, which is really difficult to find in the current political moment. So I really appreciated that. We're going to get into many different things about your book. It blends so many things: education, history, investigative journalism, because you went so deep on the mother of methadone, Dr. Marie Neiswander. And so there's a lot to get into. You also blend your own story. It's part memoir. Let's just start at the beginning, though. What is it that brought you to addiction medicine?
It was really a confluence of factors, but the most pivotal moment for me, I was working in the county emergency department in Oakland, California, and a patient came in who was in horrible opioid withdrawal. He was miserable. He was retching. He was moaning, vomiting, in horrible pain. And one of the residents came up to me, one of the resident physicians who I was supervising, and he came up to me and he said, "Hey, I'd like to give this patient buprenorphine." And I had no idea what that was. I hadn't learned anything in medical school about this treatment, despite it being the gold standard for opioid use disorder, which is killing more Americans than many other things.
Right.
So I didn't learn anything about it. And I had never used it before, but he told me about it and I trusted him. And so we did it. And 30 minutes later, our patient was so much better. He was a whole different person, completely transformed. He was smiling. He was thankful. He was dressed and ready to go. He was asking if he could leave now. He felt so much better, very appreciative. And this kind of transformation is not something we see, even in the emergency department.
Yeah.
It just sort of blew my mind because the interactions that I had had up to this point with people who use drugs in the ER were not typically positive. I didn't feel like I had anything to help. I didn't feel like I had anything to support them. I thought they were trying to manipulate me. This was the informal curriculum that I had learned in medical training. Mm-hmm. And to see this just changed my mind. And I couldn't unsee it after that, and sort of the rest is history.
Yeah, I think people listening to this would be surprised to hear you say this thing that is the gold standard treatment for addiction is something that you didn't receive training for in medical school, something that you were not familiar with at all. And so to someone hearing that for the first time and who's shocked by that, what would you say to them? What's the explanation for that?
It is shocking. They're right to be shocked.
Yeah.
And my medical school wasn't unique. Some people might think, oh, well, your school is just crazy. Everyone else learns this stuff, but they don't. There might be a handful of schools that are doing a better job, and more schools are doing it now. But I didn't learn anything in residency. Even my emergency medicine textbook, which is, this thick, didn't talk about this at all. It just talks
Really?
about if someone
Wow.
comes, yes, nothing. It was just, if someone comes in an overdose, here's how you give them naloxone. And that was it.
Okay. Great.
That was all it covered about addiction
Yeah.
or chaotic
Horrifying.
drug
Genuinely
use.
horrifying.
Horrifying.
Yeah.
And I think part of this is historical. Doctors have been sort of pushed out of addiction medicine ever since the 1914 Harrison Act passed, which was a federal tax act. It just said that opioids, you can't buy opioids over the counter. You have to have a doctor's prescription. And then there was a Supreme Court case about this in 1918 that basically decided giving opioids to people with addiction to keep them comfortable is not legal. We can't do that. We can't do maintenance treatment. And they started going after doctors and arresting them. And so doctors just sort of said, okay, well, we're not going to work with addiction anymore. We're out. And it's sort of been seen as a separate field. It's been the purview of law enforcement, of incarceration, of religious movements, of behavioral whatever, but it hasn't been medicine, hasn't been seen as in the house of medicine since then.
Yeah. You talk a lot in the book about the difference between like the systemic barriers that exist, and you also talk about kind of the individual and whether the individual can change their own perspective. And I know you know, through your education and expertise and through your lecturing and all of the work that you do in this area, that you have met with people and changed their minds on this issue, and you have been able to change people's hearts and minds. And that's a really powerful thing. What is it that you think works for people? Because oftentimes we see you can tell people facts, you can tell people data, you can give them research literature, you can tell them the way that things actually are, and still there's this resistance that you get from people to accept the reality of the world. Given your experience, what are things that actually work to convince individuals of what they should do, what they should believe about addiction?
That was shocking to me also, that so many people weren't swayed by the facts and figures, even doctors. You know, I thought that science was something that is objective. And if you just give people the correct data, they'll come to the same conclusion.
Especially scientists.
Right. Right. You give the data to the scientists and then they come to the same conclusion.
Right, right.
And so that blew my mind. But for some people, it works. For some people, the data does work. For other people, that stigma is just so rooted and so lodged that they can't even see beyond it, I think. And so that's what I was hoping to do with my book, is to have a story. And maybe the story can get to the empathetic core and people might have an opinion change that allows them to better see the data. Mm-hmm. I reviewed a paper recently that showed that doctors like me talking about it is actually not that helpful. It doesn't change that many people's minds.
Really?
But if you get people, yeah. I sort of was disappointed when I saw it. I was like, oh. Oh, well. But I think talking to people who have been through this and have the lived experience is also very powerful. And that's what that paper suggested, is that people who have been through recovery, who have had these horrible experiences being treated poorly in healthcare before, hearing them talk really changes people's minds as well.
That was a particularly powerful moment of the book because you're pretty open, right, about your own personal evolution and how you view addiction. And part of that is just the messages that were sent from society. Part of that is the education, right, or lacking in education in the program. And your evolution in how you viewed addiction and how you viewed people who use drugs and struggle with drug use. And there was a man, I believe his name was Christopher in the book. I don't particularly remember his role, but I remember you were describing this moment where you were watching him give this passionate speech. And he was talking, for example, about like people who don't use person first language. And you, at the time that you were in the room with him, you weren't someone who was even familiar with what that meant, or you weren't accustomed to using that language. And so you felt kind of attacked. And I feel like those moments in the book where you're really open about your own views at the time and how they have changed, it's helpful to see that, because oftentimes in stories, it's, I started here and I got here, and we don't get to see the messy bits in between. But you gave us a glimpse into that. Did you do that on purpose? Was there a purpose to showing kind of the in-between of you changing your mind on those issues?
Yes. I hoped I might bring people along who are still in that journey too. I didn't want to talk to people who already thought just like me. I didn't feel like there was a point in that. So I was hoping this could reach some readers who maybe also had some doubts about what the best policy is for people who use drugs, who had some of their own biases. I didn't want them to feel attacked. I wanted to show that we can all do better and we can all learn.
Yeah.
And this has been a journey for me to maybe bring someone along on that a little bit faster. If I could bring someone along just through reading my book and they don't have to go through the multiple year journey, wouldn't that be great?
And I think one of the points of that speech that Christopher in the book was making was that line about nothing about us without us, that is kind of fundamental in the harm reduction movement. And that's something that you really try to center in your story too. Can you talk a little bit about, for people who may be watching this who are unfamiliar with harm reduction, what is harm reduction and what does that look like in medicine?
Yes. Harm reduction is something that we practice all the time. It's both a philosophy and a practice. When we go into our car, these metal flying contraptions that race down the street, death boxes, we put on our seatbelts, we have airbags. That's harm reduction. We're reducing the risk of harm from doing something that could be dangerous. When I go out in the sun here in Tucson, I put on sunblock. That's harm reduction. So we're practicing it all the time. Just things that you do to reduce the risk of a dangerous thing. Reduce the harms, right? Mm-hmm. In terms of substance use, it's also pretty broad. It could be giving out naloxone so people don't have to die from an overdose. I really don't believe that any overdose should be fatal. We have naloxone, which just reverses it immediately. Very few side effects, very safe medication, very cheap.
Right.
Giving out clean syringes to people who are injecting so they don't have to share syringes and get hepatitis C or HIV or other soft tissue infections that are very painful. They can change the course of their life and they cost the healthcare system a lot of money. That can all be prevented. There's a lot of resistance to this because people think that if we're giving people cleaner supplies, that we're encouraging drug use, but really we're just telling people that their lives matter and we care about them. And all the studies show that these programs actually reduce drug use, even though that's not necessarily their intention, but they do. It's an unintended consequence. And more people who receive these services are likely to go into treatment. So by empowering people and making them feel valued, they start to treat themselves as such.
Mm-hmm. And I think that that's the important thing about this book is that it really kind of exposes the need for empathy. And I think a lot of times when you encounter people who maybe haven't had personal experience with addiction or don't know anyone in their life who has struggled with drug use, that there's oftentimes that's the missing piece, is the empathy piece. What has your experience been in having these conversations with people when you see that empathy may be the missing piece? Is that difficult for you? How do you get around that? How do you engender empathy in someone who maybe is not having so much of it?
I don't know. I don't know what to say when people say something just horrible. I'm just always kind of shocked. But the most profound teaching moments that I've seen are when people maybe aren't saying those things out loud, but they are thinking it, and then they have an experience that changes their mind. For example, I was working with one of our residents, our ER residents, did a rotation with me at the Methadone clinic, and we were just seeing patients all day. And at the end, he said, "Melody, I think you've forgotten how profound this is. When we see these patients in the emergency department, they are in crisis. And then a few days later, they're here in the methadone clinic and they look like a whole different person." And he was like, it's just hard for me to remember that in that moment when we see someone in crisis, that this isn't their everyday. This is just the worst moment of their life when we're seeing them. We can choose to help them and then they'll be doing better. And he was just to see how profound that was for him was very heartwarming for me. And so I think giving people these experiences so they can see with their own eyes is very helpful in fostering empathy.
Well, and you write a lot about your hero, Dr. Marie Neiswander, and the mother of methadone. And for people who might not be familiar with what methadone is, maybe we should kind of start there. What are some of the medications that are actually used to treat opioid use disorder?
The main two are buprenorphine and methadone. They themselves are opioids, just like oxycodone, just like fentanyl, just like morphine, but they have some different properties that make them much safer. They have a long half-life, so they're very slow to start acting, and they last for a long time, so people aren't getting these highs or lows with it. They just feel normal for the first time. I've had so many patients, when they get put on these medications, they say, "Thank you. I've been trying to feel normal for the last few years. Since I've been using fentanyl, I haven't really gotten high anymore. I haven't felt good. I just use it so I don't get sick." And with buprenorphine and methadone, people don't get sick. They also don't get high. They just feel normal. They can go back to work. They can go back to school. They can repair relationships. They can get healthy again. And they're also safer because we know exactly what's in them. They're regulated. You can go to the methadone clinic or to a pharmacy and get them. You know exactly what's there versus getting fentanyl from a guy at the Circle K. You have no idea what's in there. Right. There's hundreds of different fentanyl analogs. People are putting other substances like xylazine or stimulants or whatever into the fentanyl, and you don't know what it is. So it's much safer. It's harder to overdose, and it gets rid of some of the behaviors of addiction too. So even though people are still dependent on buprenorphine or methadone because they are opioids, they are not addicted. Being addicted to something is different than just being dependent. I mean, you could say that person with diabetes is dependent on insulin. They have to take it every day, but they are not addicted. You can say the same thing about bup and methadone. And they have a whole team of medical professionals who are supporting them, supporting their recovery. They're not lying about this. They don't have to hide it. Those negative behaviors of addiction are gone.
And there's a lot of barriers for people accessing these, again, what you said are the gold standard treatments for opioid use disorder. And some of those barriers include like doctors struggling to get the license needed to dispense the medication. Some of it is pharmacists not filling the prescription if they're able to get the prescription. Some of it is with methadone, you have to actually physically go to the clinic. Can you talk about some of those barriers to people that are actually in need of these medications and the struggles that that get in the way of them being able to obtain that treatment?
There are barriers every single step of the way. It is so much easier for people to get the poison than it is the cure. The biggest barrier with methadone is that people have to go to the clinic to get it. So you can't go to your regular doctor. You can't go to your regular pharmacy. You have to go every single day to a methadone clinic. And there aren't that many in the country. Half of the country doesn't have one. The whole state of Wyoming doesn't have a single methadone clinic.
Wow.
Yes. And for much of rural America, it might be several hours away. So that's the hugest barrier, is just having a clinic nearby.
And even, I mean, think about that for the audience's sake. I'm speaking to the audience now, you already know. But in terms of taking a vacation, in terms of traveling, what if you have a family emergency and you need to leave and you need to go out of town? You have to be thinking, well, how am I going to access this medication that I need to show up somewhere in person in order to get it every day?
Yes. Yes. I've had so many patients who that's come up. They had a family emergency. They had to leave and they relapsed because they weren't able to get any methadone. They didn't want to relapse, but they felt horrible. They felt sick.
Right.
I had another patient who was doing very well on a family vacation to Hawaii and had to fly home early because he couldn't guest dose at the methadone clinic out there.
Wow.
Just these extreme barriers. I have a colleague who was on methadone who went on a European vacation and couldn't get methadone and again had to fly home. I mean, these are just people who are trying to do well and have normal, happy, productive lives. And there's barriers over and over again.
Yeah. And you also talk about barriers related to the number of doctors that can offer these treatments too. Some of those numbers were pretty shocking to me in the book.
Yeah, less than 2% of doctors prescribe these medications. And you really can't prescribe methadone unless you're at the clinic. Or the hospital. I mean, I'd give it at the hospital, but I can't give someone a prescription for it.
And even you said in the book that you can get a methadone prescription for pain control, but when it comes to addiction treatment, that's not something that you can get. And I'm sitting here thinking, what is the, I think a lot of times people think like our drug laws are based on logic, but you also cover in the book that they're pretty much just based on racism, right? I mean,
yes.
Can you go into that actually a little bit? Because it is an interesting history for people who don't know. Our drug laws are not necessarily based on logic. In fact, they're not. They're based on racism.
No. Yes. Ever since the beginning. Yeah. So our country's first anti-drug legislation was in the 1800s in San Francisco, and it was targeting opium because there was a huge racism stigma against the Chinese population at the time. Lots of white San Franciscans thought that Chinese immigrants were stealing their jobs. And so going after opium was a way to target them, to persecute them, arrest them, barge into their communities and their businesses and homes and harass them, basically. So that was our country's first drug legislation. And then in the early 1900s, at the peak of segregation and lynchings and the Jim Crow laws, there was an article in the New York Times written by a physician talking about crack cocaine and the cocainized black man and how dangerous they are, and actually encouraging different police departments to increase the caliber of their weapons because they thought that black men on cocaine were turned into monsters and needed bigger weapons. And it's just horrific. And
it sounds like something that couldn't possibly be true, but it's absolutely true. That's what is wild. Yeah.
And the legacy of this still continues, looking at Elijah McClain in Colorado, how they gave him a much higher dose of ketamine that was needed, which caused his death.
Right.
And that's because they thought a black man needs a much higher dose of sedative, which is not true. There are studies where they actually ask medical students, do you think black people or white people, who needs more pain medicine, who has a better pain tolerance? And even medical students have this racism baked into their medical judgment.
And it sounds like it's something that's covered in medical school, like they're trying to address that. Is that?
Yes.
Okay.
Yes, we're trying to address that.
Yeah, that's good.
But still, people don't even realize, I think. And more anti-drug legislation in the 1980s. Of course, there was the 1986 Drug Act, or there's an act in 1986 where the mandatory minimum for crack cocaine was 100 times greater than powder cocaine, effectively targeting the black community who more often used crack cocaine than powder cocaine, and causing a huge uptick in our incarceration rates around black Americans.
Well, you also write in the book, you say this, I'm going to read it back to you. I don't know how authors feel about this when this happens during interviews, but we'll see. I really, really liked this sentence. You said, until we radically change our perspectives around demand versus supply, around disease versus crime, and around recognizing our shared humanity versus vilifying the other, nothing will change. And I almost felt like that comes later in the book, but I was almost like, if I'm going to pull a thesis out of your book, I feel like that might be the sentence. Can you talk a little bit more about those issues, demand versus supply, disease versus crime, and recognizing our shared humanity as solutions for what we're facing with continuing to criminalize people who are struggling with addiction?
Yes. The demand versus supply is at the root of so many of our drug policy conversations. And once I understood that, it was so much easier to understand if a policy was good or bad, if it was evidence-based or not. And we have tried this before. We've tried this so many times with the supply side enforcement. So the supply argument is, if we get rid of our supply of drugs, addiction will be cured. Nobody will use drugs anymore. And in the middle of the 20th century, there was congressional reports where politicians thought, if we just go to Burma and buy all of the poppies, we'll fix the problem. There'll be no more opium and no one will be using heroin anymore. I just laughed when I read that. I was like, how could they actually believe that was going to work? But we're still doing that. But
right. It's the Trump administration policy, essentially, right?
Yes. 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 And it was the Reagan policy too, just say no.
Yeah.
And when doctors start flooding the market with oxycodone, leading to another wave of opioid addiction, then the solution was, well, we'll just stop the doctors. We'll stop the doctors from prescribing. But then people went to heroin, and then we tried to get rid of heroin. And now we have fentanyl, which you don't have to worry about good weather leading to a good crop. You can just manufacture it in a lab. It's very potent. So you can have very small doses, easy to sneak around places and transport and distribute.
Right.
So stopping the supply has never worked, but that's exactly what our current administration is trying to do. If we just build a big enough wall, if we arrest enough Mexican people, we will stop fentanyl from entering this country. But it's all hysteria. It's all a way to persecute a racialized population and scapegoat them. And it's not effective. Stopping the demand is offering treatment. So people have methadone, they have buprenorphine, so they don't need to go buy the fentanyl anymore. But it's so hard to get the treatment, so the demand continues.
Yeah, and for me, not to be petty, but it's frustrating hearing that argument from people who believe that, if they touch fentanyl, they're going to have a panic attack, or they're going to overdose. What they're really doing is having a panic attack. See, I couldn't even get it out. I couldn't even say it. It's like my body rejected it as I was trying to get it out.
I worked with a pharmacist, and she was like, pharmaceutical industry spent a lot of money making a transdermal fentanyl patch. To get that technology to get fentanyl through the skin took a lot of research and development money. It's not easy.
Yeah. What about the disease versus crime aspect? So we're still in a place where we are mostly our policies, right, are criminalizing addiction, right?
Yes. Yes. Every day I feel like I read the news and there's a new headline about a fentanyl homicide law that we're making. So if someone sells their friend a fentanyl pill and they overdose and die, that person is going to be sent to jail for homicide. That's not helping anybody, but we continue to see addiction as a crime. And so we're trying to arrest our way out of it. But addiction is a medical condition. There are functional MRI studies that show how brain pathways actually are changed by drug use, how the hallmark of addiction is that people continue to use despite the harms that it's causing their life. So creating bigger sentences, more penalties, that's not going to stop people from using, because that's the nature of addiction, is that people keep using despite the harms.
It's just literally the diagnostic criteria in the DSM, right?
Yes,
yeah.
Yes.
Yeah. Yeah.
But we're still not convinced. And I think on the surface, people are like, oh yeah, addiction's a disease. Yeah, sure. But when it comes down to it, they don't really believe that. They still think it's a moral failing. They still think it's something wrong with that person, maybe a spiritual failing. And so if you think that, then you don't think that the treatment is medical.
There's so much that needs to change, right? And that really comes through in your book about all the different obstacles and all the barriers in place. There's so much that needs to change. What would you say is like at top of mind for you? What are things that you're really focused on educating people about? What do you think are the main things that you think need to change right now to get us to a place where we're seeing some forward movement?
I really think understanding the history is important. People think that it's dry and boring, but I try to change that idea in my book and say, no, it's an interesting history. It's fun, it's alive, and it very much is influencing what we're doing today. We just keep repeating the same mistakes over and over again. So understanding that historical context, I think, is helpful to see the way forward. I focus a lot in the medical community and just trying to change our hospital policies to make these medications more accessible. But man, it's a uphill battle.
Yeah, and that really comes through. I mean, there were, well, no, I'm saying about the rage that you would feel sometimes, right? I would be reading it and I'm like, I feel this rage too, right? There were probably 5 times more than that where you're like, and I just sat there and I was typing and I was raged, and it really comes through because you do feel that you're up against this system, right? And, I'm a licensed psychotherapist. I worked in a court mandated treatment program in California. I have worked in inpatient psychiatric facilities. I am familiar as well with the systemic issues that exist across the board for people that want to do good work. And it becomes very frustrating when you are a person who, goes to school for a long time and you're in debt for going to school for a long time because you want to do good and you want to help people. And then you get in there and you're like, wait a minute. What's going on with the way the system is set up, and why am I constrained from being able to help people in the way that they need to be helped, in the way that is going to be most successful as far as outcomes for them to be the healthiest they can be? And so that's what really comes through is, number one, your care and concern for the people that you're treating, but also this passion that you have for changing the system and wanting to improve things and make things better. And like you said, it's kind of a domino effect, right? You get to train someone, you get to educate someone, then they go on to educate someone. And it really is this important cycle. So I know it's difficult to be in that situation, but is there hope that you get, I guess, from being in the position that you are, where you are able to educate, you are able to, pass the torch from Marie forward?
Absolutely. Absolutely. And I've seen a lot of change, even in the last 6 years that I've been here in Arizona. When I came, I was the only addiction medicine faculty in my department. I think there were 2 of us in the whole hospital. Now that's different. There are tons of residents and medical students who are passionate about this, who want to learn this, who have learned more about addiction in medical school, and they're eager to continue that on in residency. We have fellows who are very active and engaged. We have these medications available now. Things have definitely changed for the better in a short time. And so I keep trying to remind myself that we have made change, although in the moment it might feel incremental, it might feel insurmountable, some of these systemic barriers, but we are doing it. And there's definitely a lot of hope there.
I love that message. And I think it's a good place to start wrapping. And one of the themes of your book is also change, right? I mean, you're open about your own evolution, the ways that you've changed your mind. You're encouraging other people to change their minds. It's been kind of a theme. And that's a theme on my show, too. I talk a lot about changing your mind with your understanding of the evidence changing. And so, in the spirit of that, I want to ask you, what is the most recent thing you changed your mind about?
So this doesn't have anything to do with addiction.
Perfect.
Yes, but in our household, I've become very rigid about recycling plastics.
Okay.
And this was something I wasn't doing before because I thought this was a systemic problem, that our country is not really focusing on recycling or on the environment, and we're pawning off this systemic issue as an individual thing.
Yeah, you're like, what? Why am I going to recycle if Taylor Swift is flying around in her private jet? What's the point?
Exactly. And one of the residents told me recently, he was like, recycling is like a big group project where no one's doing a good job.
What a reframe.
I was like, exactly.
Yeah.
And so I was just like, why? Yeah, why should I do this? I'm not helping anybody. It's not making a big enough impact. We need systemic policies. Let's stop making these giant corporations get off the hook by framing it as an individual problem. Let's hold them accountable. Mm-hmm. And I still want to hold them accountable. But I also have decided I'm going to recycle plastics and take this extra step. I have to go to a special place to drop it off with my special orange bag. They're going to turn it into bricks and build buildings. I'm still going to do it because at least I won't have blood on my hands. And I know I'm doing my best. And I'm teaching my daughters. I'm teaching them that we can take steps to make a difference.
Yeah, so kind of that passing of the torch again, that theme. And also I get the sense like you don't want to be the one in the group project dragging everybody down. Like if we're looking at you in school, I find it hard to believe you would be the one in the group project dragging things down, right?
Right. That's accurate.
Makes a lot of sense. Well, I cannot say enough, Dr. Glenn, about how much I appreciate your book. I think it's so educational. This is something we need to keep talking about. There's so many competing issues right now that are drawing our attention, and mostly the fascism. But like I said, I felt so hopeful when I read your book about people's ability to change and about, how we can all work together to really make a difference. And I just think that this is a powerful message, and I think the audience will really appreciate it. So definitely you can get Dr. Glenn's book now. It's out now, and I will pin a link in the comment for you to get it. And again, Dr. Glenn, I appreciate your time. Thank you so much for being here.
Thank you so much for having me, and thank you all for watching.